Dr. Jeff talks love. Dr. Jeff talks life. Answers your questions, cuts through the strife. Sex and intimacy, real and true. Evidence-based, made just for you.
Hello. Welcome to Dr. Jeff Talks About Sex and Intimacy, where we have open, honest, and evidence-based conversations about sexual health, about relationships, intimacy, and well-being. I'm your host, Dr. Jeff Albaugh. I'm grateful you're here with me tonight for another discussion designed to educate, to support, and to remind you that, guess what? You are not alone. This is episode 72, Focal Therapy for Prostate Cancer, Precision Treatment, Preserved Quality of Life. Whether you're watching live or listening to the recording, every moment of your amazing life matters, and I am truly grateful that you are joining me and us to learn more about this important topic. We're connected across so many platforms. We're on Facebook, we're on YouTube, we're on X, we're on LinkedIn. A quick favor, if you are a Facebook person, please follow us. The more people who follow us, the more we can do on Facebook. We appreciate all of our streaming on all those different platforms. Visit the website. If you want to learn more about upcoming episodes, you can pull up the calendar and see all the amazing guests we have scheduled all the way through August. You can go back and watch past episodes. There's 71 of them with experts in all kinds of topics on relationships, on sexual dysfunction, all kinds of things. So go to the website. You can take us with you. We are where you're going. If you want to work out with us, Dr. Jeff Talks About Sex and Intimacy. Wherever you go, we are streaming on Spotify, on Amazon, on iHeartRadio, and more. So if you're going on the road, take Dr. Jeff with you because you can learn more as you travel. As always, I would like to take this moment to welcome you here. Whatever your sexual orientation, whatever your gender identity or your relationship style, this space was created for you. The mission of the podcast, it's pretty simple. It is to empower and enlighten you with the evidence-based information that improves your sexual health, deepens your loving relationships, so you can live your one miraculous, wholehearted life with more love. Who doesn't want more of that? Well, tonight we are talking about an important shift, really important shift happening in prostate cancer care. One that focuses not only on treating cancer effectively, which is monumentally important, but also on preserving quality of life. Prostate cancer is a very survivable cancer, but often quality of life, intimacy, and sexual health can pay a price for getting rid of the cancer. For many men, a prostate cancer diagnosis can bring fear and uncertainty, especially around treatment side effects like erectile dysfunction, urinary changes, and loss of confidence or connection. But guess what? Advances in medicine are creating more personalized options. One of those approaches is focal therapy. It is a precision-based treatment designed to target cancer while minimizing damage to healthy tissue. Joining me tonight is a leading urologic oncologist, Abhinav Sidana, who will help us better understand what focal therapy is, who might benefit from it, and how these newer approaches may help men maintain both health and quality of life. So we're going to dive into this, and I will tell you, I've run a prostate cancer group for a long time, and this is such an exciting time in prostate cancer treatment because we have been waiting for more targeted, more focal therapies. We've been working towards really good precision medicine, and I can't think of anyone better than my guest tonight. Abhinav Sidana is a fellowship-trained urologic oncologist. He specializes in prostate cancer diagnosis and treatment with particular expertise in focal therapy and image-guided approaches to prostate cancer care. His clinical and his research work focuses on precision medicine strategies that aim to effectively treat the cancer while preserving urinary and sexual function whenever possible. Dr. Sidana has authored numerous peer-reviewed publications and is recognized nationally for his work in prostate cancer imaging, in focal therapy, and minimally invasive treatment techniques. He is passionate about helping patients make informed, individualized decisions that align with both their medical needs and their quality of life goals. I am really excited to welcome my guest. I can't think of a more important topic than this for prostate cancer patients. And who better than my guest tonight? So welcome. Thank you for being here, Dr. Sidana.
Thank you so much, Jeff. Thank you for the kind introduction. It's my honor to be here today. It's my privilege to be chatting with you on this important topic and interacting with you and your listeners.
We both know that we have this weird thing going on in Europe. Sometimes we feel like, gosh, we want to get rid of cancer, and so we feel like sometimes they are not as concerned as we are with getting rid of cancer. But then they feel like in the U.S. we overtreat prostate cancer. So I think that's why this discussion is so important tonight, is to really zone in on all of that.
I agree. I think prostate cancer is a unique disease. It affects a very high proportion of men in America, but still the men who die from prostate cancer are a very small percentage of men who get affected with prostate cancer. So maintaining that balance where to treat patient so that we can prevent them from dying from prostate cancer, but also not overtreat a lot of men where we're creating a lot of side effect without giving them a chance to live longer.
Yeah, and that's what's so important. It's that balance between, we want to eradicate the cancer for sure, but we also don't want to cause these other sexual and urinary side effects. So without further ado, I'm going to hand it over to you. I can't wait to hear your presentation this evening. It's all you.
Thank you. So I'll share my screen now. And as Jeff explained, I am going to talk about prostate cancer focal therapy, which is both my clinical and research interest. I've been working on it for now almost 10 years. And we treat a lot of patients every year. And also we run several clinical trials and other studies on focal therapy. So this will be the outline of my talk. We have realized over the last several years that there's a need for precision treatment for prostate cancer. For the longest time, we were treating men with just a dichotomous treatment strategy. We were either asking our prostate cancer patients to choose for active surveillance, which is no treatment, just monitoring of the cancer, or go to the other extreme, which is radical treatment, such as taking the entire prostate out or doing radiation therapy for entire prostate. And while prostate cancer has multiple different grades, multiple different presentations, we had only two options. There was no middle ground. We realized from studies like this PROTECT trial shown in the slide, this was a big clinical trial it was run in England, which randomized patients to active surveillance versus prostatectomy, which is removal of prostate, or radiation therapy. And what the study demonstrated, after 15 years, the men who did not get active treatment upfront, the men who were on surveillance, they still did not live any less longer than the men who got active treatment upfront. So definitely treatments were not making men live longer. However, the study was very clear. The men who were getting treatments were having more side effects. The men who had surgery were leaking more often, and they had poor sexual function than the men who did not get treatment. On the other extreme, it's not feasible to not treat anyone with prostate cancer. There have been studies on active surveillance where carefully selected men were put on active surveillance and they were followed for prostate cancer. And within 5 years, more than 50% of men ended up getting treatment. Either their disease got worse, or they got anxious, or they just got tired of multiple biopsies and didn't want to do active surveillance any further. The other thing which we've learned over the last 20 years is that prostate cancer has a long natural history. From the time you develop prostate cancer to the time prostate cancer eventually spreads and leaves prostate, that's a long duration. And we have that long window where we can treat with prostate cancer and cure these patients. We don't have to treat everyone at the beginning of that window. We can treat them later down the line and still achieve optimal outcome. And I think the third thing and the biggest thing which has allowed us to and actually allowed us to change prostate cancer treatment and kind of necessitated prostate cancer change treatment is prostate MRI. With MRI, we can actually now visualize prostate cancer, like in this imaging, we can see prostate cancer, which we were not able to do before. So if you can see it, we have better risk stratification, we can better treat it. And that led to focal therapy. Focal therapy is guided ablation of an image-defined and biopsy-confirmed prostate cancer along with the surrounding rim of normal tissue. And the goal here is to just eradicate significant cancer and still preserve genitourinary function, such as sexual function and urination. How do we achieve that? There are multiple ways to achieve it, but we use one of the energy modalities, FDA-approved energy modalities, to destroy prostate tissue using the information provided to us by MRI. So who are the best candidates for such treatments? Patients who have clinically significant disease defined by Gleason score 7 or grade group 2 or 3 disease, and with the PSA less than 20 are the ideal candidates for such treatment strategy. They should have cancer only in one spot of the prostate, or at the maximum involve one half of the prostate. If the cancer is involving both sides of the prostate, then those patients would not be a good candidate for focal therapy. And to have optimal success for focal therapy, these cancers should be visible. Focal therapy is not a great treatment if you cannot see prostate cancer on MRI. So we need to have ability to see prostate cancer so that we can destroy it more effectively. And of course, this is treatment which is less aggressive management than radical prostatectomy or radiation therapy. So we want to ensure that there's no high-risk features in your prostate cancer. Cancer should not involve seminal vesicles. Cancer should not invade outside the prostate capsule or have high-risk Gleason grades. How do we achieve focal? One of the most commonly used modality is called cryoablation or freezing. This has been around the longest, more than 40, 50 years to be used in prostate cancer space, but we have modified it over the last 10 years to make it more precise so that we can accurately destroy just the prostate and not destroy and not create a lot of side effects. It gets achieved by freezing the prostate tissue, which breaks the cell membrane and releases the cytoplasm and results in the death of the prostate tissue. It's achieved through a brief procedure, around 45 minutes to 60 minutes under anesthesia. Patients are under general anesthesia, where we put 3 to 4 needles in and surrounding area of the prostate cancer, and then we turn the machine on. It freezes the prostate tissue and kills the prostate tissue. The recovery is really fast. Patients have catheter for 5 to 7 days. However, the outcomes in this era are much better with freezing than it was, several decades ago. Most men are continent; they are not leaking urine. However, there's still significant impact on erections with cryoablation. The second treatment, which is the most commonly utilized in the United States, and I believe in my practice is most commonly asked by the patient, is called HIFU, high intensity focused ultrasound ablation. This is completely non-invasive treatment modality where an ultrasound is inserted in the rectum it releases sound waves, which are 10,000 times stronger than a standard ultrasound. These sound waves get focused on a specific spot on the prostate. The energy is deposited there. Temperature rises to 80 degrees centigrade and results in the tissue death. So this is a small video of the HIFU being done. As you saw in this video, the surgeon just drew this blue parameter on the prostate, and then the machine slowly and steadily destroys the prostate tissue precisely. And since the vision is so much better, we can ensure that we are causing minimal to no damage to the urethra and the sexual function. The third modality, which was approved now almost 2 years ago by FDA and is increasingly being offered, is called irreversible electroporation. In this modality, similar to cryoablation, we do put needles or electric probes around the cancer spot, and then the electric current goes from positive to negative, and any tissue between those electric probes get destroyed because there is creation of small nanopores in the cell membrane. This results in a death of the prostate tissue. However, the tissue scaffolding is maintained. Again, this is also not a thermal ablation, which means it doesn't use heat. It uses electric current for ablation. So potentially, there is a better preservation of sexual function and urethra with this modality. And finally, this is probably the most commonly offered at University of Chicago, as we are one of the only centers in this region offering this modality. It's called TULSA, MRI-guided transurethral ultrasound ablation of prostate tissue. This is, again, a non-invasive way of treating prostate cancer. This is also an ultrasound-guided modality similar to HIFU. However, in this, the ultrasound beams come from inside the urethra to the outside. And as you see in this photograph, it is done under MRI guidance. And MRI also allows us to measure the temperatures and make sure that we're achieving optimal tissue death while doing this procedure. We looked at our initial analysis. Back then, we were only offering cryo, HIFU, and IRE, and we demonstrated that these men maintained their urination. Almost everyone was continent, and 90% of them maintained their erectile function. In terms of cancer outcomes, we follow these patients very closely. We get PSAs on them every 3 months. And then at 1 year mark, we get MRI and biopsy on every patient. And we demonstrated that only 17 to 20% of these patients have recurrent Gleason 7 in their prostate. 80% of these patients had no cancer in their prostate, which was significant. So is there still a role for prostatectomy in precision medicine? And there is. Prostatectomy still plays an important role in men like this patient where there's just too much cancer, which cannot be destroyed by focal therapy. Cancers involving both parts of the prostate, high-risk prostate cancer, or patients who have just high-risk genomic features. Either they have genetic mutation or they have tissue testing such as Decipher or other similar tests which demonstrate that patient had a high risk of bad outcome from prostate cancer. And also, this is a treatment for patients who just do not want focal therapy, right? Focal therapy involves future MRIs and biopsies, and some patients are just not ready for that. They want one treatment which can take care of their cancer. And for them, prostatectomy is a great treatment option. And sometimes focal therapy is just not feasible. The patients have unfavorable location of the tumor where when we destroy them focally, they might still have significant impact on their urination and sexual function. So in those cases, we opt for prostatectomy upfront. So to conclude, Focal therapy is a personalized treatment option, and it's integral to precision prostate cancer care. Unlike active surveillance and radical prostatectomy, which are essentially offered the same way to all patients, focal therapy is very personalized. You can dial it down, you can dial it up. You can treat somebody less aggressively with focal therapy, or you can treat somebody more aggressively with focal therapy. Robotic radical prostatectomy still has a big role in precision medicine if it needs to be just refined and strategically employed in patients who are optimal for such treatment strategy. We have demonstrated that advancements in prostate imaging and in accurately detecting, localizing, and risk stratifying prostate cancer has allowed us to offer this treatment strategy to our patients. And in intermediate term outcomes, focal therapy has performed really well in terms of oncological outcomes, and it has excellent functional outcomes, means it has excellent role. It does really well in preserving urination and sexual function. We need further research to enhance patient selection and optimize the outcome of focal therapy and further define the surveillance after focal therapy. Thank you.
Wow, excellent. So, for any of those listeners out there, if you're struggling with prostate cancer, I know it can be daunting, it can be frightening, it can be scary. But I think, Dr. Sidana, what's so interesting about it is, so we have, sometimes people don't realize that it's very personalized depending on your Gleason score, on how aggressive your cancer is, on your PSA, on many, many factors, your health status. That's how we kind of determine what might be the best thing for you. And some people think, oh my gosh, active surveillance, you don't do anything. But we do have a very robust, and actually the newer AUA guidelines say this is the right treatment for the right patient. So again, it's very personalized, but so it doesn't mean should everybody not treat, not in any way, shape, or form. But what it means for the right person, treatment might not have to happen. They need to be watched, they need to be looked at, but they may not need treatment. They may never need it in their lifetime, or they may need it at some point. But that's important to remember. And then in the past, we always had the extreme of we're going to take it out, your seminal vesicles, all of the lymph nodes around there, everything's coming out. That's a radical prostatectomy. What's so great about this is, so we have each end of the spectrum, but now we have the middle of the spectrum and continuum, which I think is really exciting. And so I love the way you guys kind of sit down, you even discuss as a group each patient, because even these focal therapies, there's certain ones that would be right for a certain man, depending on where his prostate cancer is located. Can you talk just a little bit about all of that? Because this is such an exciting thing to have that continuum, that spectrum from we don't need to treat your cancer in this particular case, if you're comfortable with that, all the way to we're going to do a radical prostatectomy, and radiation therapy falls into there too.
Thank you. Jeff, you summarized it really well. And I think active surveillance is definitely a step in the right direction, right? 20 years ago, we did not even offer active surveillance. We only offered surgery or radiation for every patient. You have a tiniest amount of prostate cancer, whether it has any potential of lethality or not, you got your prostate out or you got radiation. Then we made advancement and we realized that small amount of prostate cancer, low grade, has low implications of causing metastatic disease, low odds of causing metastatic disease. So we started treating this patient with active surveillance, right? So we active surveillance on this end, prostatectomy and radiation therapy on this end. But for the longest time, there was nothing in the middle. And focal therapy now fits right in the middle, right? It takes over where active surveillance becomes less ideal. So for patients who are good candidate for active surveillance, I think they should get active surveillance. They should not get focal therapy. Focal therapy is not for those patients just because you want something to be done for a disease which does not need treatment, right? If you don't need treatment, I think you should still get active surveillance. But then from there to all the way down to the prostatectomy, there are multiple grades, multiple presentations of prostate cancer. A lot of them can be treated with focal therapy, and we don't have to do prostatectomy. And I think that's why focal therapy is excellent, that we can treat less aggressively. A patient who is just barely not an active surveillance candidate, we can treat them less aggressively. However, there are a lot of patients who have much more disease. They were never active surveillance candidate, but they have just not met that criteria for prostatectomy at this point. I think those patients can get focal therapy. So it's a wide range of patients who can get focal therapy. And so at U Chicago, our workflow, and I think we chatted about this and in depth the other day. When we see patients for focal therapy, we don't right away book them, right? We gather all the information. We make sure we note down all their preferences. How do they want to get treated? And we get their path, we get their imaging. If we need to order further testing, we get those done. And then we gather all the information and take it to our bi-weekly, we call it PIC meeting, prostate imaging conference, where we sit with radiologist, other urologist, fellow, nurse navigators, our nurses, and go over every patient in depth. And then we decide, is this a focal candidate? Did the imaging miss something, or the initial read of the imaging miss something? And if everything looks good, what treatment modality would be the best for this patient? And that's why we have 5 treatment modalities, right? We are not offering just one focal treatment. We have 5, because some patients are eligible for first treatment modality, others are eligible for 3 of them, and some patients are only eligible for 1 of them, right? So we need all those treatment options so that we can treat patients with any tumor location if they're candidate for focal therapy.
Yeah, it's very exciting. And you think, now you have all these more choices, and especially depending on your particular situation. So as Dr. Sidana was saying, in the past, you had surgery or radiation. And one thing that sometimes people, I know my prostate cancer patients and the ones in my group, were concerned, if you do radiation therapy as your primary therapy, now surgery's off the table. But what's nice about focal therapy is if you do the focal therapy, further surgery is not off the table. You can still do other treatments. And so I think that's important for men to remember, because one of the reasons I think why men were choosing the radical prostatectomy surgery over the radiation therapy was, if they needed more treatment for their cancer down the road, absolutely, it is a standard of care to follow that up with radiation therapy. And by the way, there's 3 forms of radiation therapy: external beam, especially for primary therapy, external beam, seed therapy, and proton beam. And so we have a lot of choices. What's difficult about that before, and even more so now, is navigating it. We always say in our prostate cancer group, the greatest thing about prostate cancer is there are many treatment options. The hardest thing about prostate cancer is you have to pick one that feels comfortable and feels like the right one for you, because ultimately you will do the choosing. And that can be really challenging for these prostate cancer patients, because they're like, I'm not sure what to do. I don't know what to do. But I think it's great that you guys meet as a group. You come up with, these are your viable options. So at least you're kind of saying, we don't think you're a great candidate for this or this, but these are the things you are a good candidate. Here would be the pros and cons, so you can make your own informed decision about which one you want to do.
Yeah, no, and I think that's the goal for the whole process, is to empower our patients to make their own decision. When I was a medical student, I ran a project asking patients about their preferences for prostate cancer treatment and the regret they had after the treatment. And one thing I learned really quickly is, I think we need to empower patients to make their decision. It has to be informed decision making,
Yes.
not shared decision making, and definitely not a decision making of a physician. I think my goal is to educate them about these options. And there are some patients who have perfectly great focal patients, and I really want to tell them you should choose focal therapy, but they choose prostatectomy and I perform prostatectomy. I think ultimately is their decision. We can only educate them what the options are, and I think ultimately, since they are going to be living with their decision, I don't want to make a decision for them. So this workflow has definitely helped a lot. Also, it gives them time to decide, because while we are waiting to get all this imaging reviewed and everything, they are aware of the options. They give another 1 month to think about it, and we chat again in 2 to 3 a month later, probably most of the time. And then if they have further questions, we answer them. And if the committee thinks they're focal candidate, we answer all their questions. And if this is what they want to do, then we book them for focal therapy.
So listeners, you might be thinking, wow, that's a lot of time. You got cancer. Remember, prostate cancer is slow growing. You have time to make an informed decision. That's really a really helpful thing. Most prostate cancer is found early, and you have time to make a really good informed decision. And so over and over, you'll hear us talking about it ultimately is your decision. And I know it's difficult. Another really exciting thing, and I know you're doing this at University of Chicago, is now we have focal radiation therapy as well. So it's not just even surgery now. And again, if you have prostate cancer on both sides of your prostates bilaterally, then you're probably not going to be a candidate for this type of thing. But those men who have a focalized prostate cancer, radiation therapy can also be done in a way that does not radiate the entire prostate now. So really exciting time for prostate cancer treatment. Really cool. So then listeners, you might be like, oh my gosh, how do you decide? Well, and even this, as Dr. Sidana said, and the day he came to see us, he had done a radical prostatectomy on someone who was a brilliant candidate for focal therapy, but wanted to do the other. So I know he always goes with whatever the patient says. But here's some things to think about, because then people are like, oh gosh, focal therapy sounds so great. Maybe I made a mistake. A couple things to think about. A lot of men, what they like about radical prostatectomy is that your prostate is gone. PSA is prostate specific. So when your prostate's gone, the nice thing is PSA becomes a really good marker to see if you have cancer reoccurrence now. Because without your prostate, PSA can only be produced by that prostate cancer now. So when you do focal therapy, it's going to be a little different, because remember, you'll still have a prostate, right? And then if you do active surveillance, again, you're watching things, you're looking at things. So again, you have to think about all of that. How much are you into definitive? I know it's all gone. I know they checked my lymph nodes. They did all that. That's a radical prostatectomy patient who wants that definitive information and can settle for nothing less. Whereas the focal therapy patient is a person who's like, I want you to preserve as much as you can. I want you to get that cancer. Now their PSA, they're going to have to watch that. Active surveillance. None of these things are for everybody. You have to make your own informed choice, because who are you and what's right for you? Someone listening the night you came and talked to my prostate cancer group was like, wow, this kind of, now I'm like, oh my gosh, the focal therapy. But he kind of said, I'm a really definitive guy though. And I just don't know that I can live with my PSA not going to undetectable. So again, there's a lot of things that go into the decision-making process.
I agree. I think all you summarized it well. Prostatectomy, one of the biggest advantages, PSA goes down to 0. So it becomes a binary marker. If PSA is 0, you're good. If PSA is not 0, then we have to be worried about. With focal therapy, like radiation, the PSA doesn't go down to 0. So it goes down to some really low number, and which is different for every single patient. And then we start monitoring their PSA from that low number. But that's why we need to do more imaging in focal patients, because they still have almost 70 to 80% of prostate left remaining. And they still have the same risk factors which caused prostate cancer in the first place, right? So they can form another prostate cancer, or they could just have residual disease from the first treatment.
Yeah, but it's exciting, because I know you've really been watching either recurrence or other cancer, prostate cancer occurrences. And I know other centers are too, but I know you guys track all your patients, track all your evidence, and really look at that. And that's what is so important, because we learn so much from that. And so I think that's really great too. So I guess the most important thing is really for people to understand, wow, we have some really good choices out there now,
Mhm.
and there are more choices for you along the spectrum from do you need to watch very carefully with active surveillance through, you have focal therapies such as focal radiation and multiple focal techniques to treat prostate cancer. And then we have the radical prostatectomy as well, a full spectrum of things
Mhm.
depending on your particular circumstance and what's right for you. So that's why it's so important to get a couple really good opinions, to research it fully and make your own informed choice, right?
I agree. I think that's the best way to make a decision. And again, sometimes it's not that easy because patients are eligible for a lot of options, unlike
Mhm.
other cancers where you have, okay, you have this kind of cancer, this is your stage, this is your treatment option, right? Prostate cancer is not like that. For most patients, they're eligible for multiple options. And I think sometimes that decision making is tough.
I agree. And I do see patients who are just like, can someone just tell me what to do? I can't stand
Yeah,
it for you to tell me what to do. It can be really confounding, but it's great to have the options too,
yep, I
and to
agree.
be informed about every option and make your own informed choice, which is the ultimate goal. So I have a good question that came in for my men listening. For men listening who are newly diagnosed and frightened, what conversations do you encourage them to have with their doctors before deciding on any prostate cancer treatment?
I think that's a very good question. When you go and talk to your physician about prostate cancer, I think you want to understand your prostate cancer first, right? You want to know what your Gleason score is, what your grade is, what is your risk category based upon NCCN guidelines, and then ask your physician about what options are I'm eligible for. Am I eligible for active surveillance? And if you are, most of the time that's the correct answer. You choose active surveillance. If you're not eligible for active surveillance, what other options can I get? Am I eligible for one of the newer focal therapy modalities? Am I eligible, or if not, then am I eligible for prostatectomy or radiation? And then discuss the side effects of each treatment modality. Both of those treatments have side effects. Actually, all treatments have side effects. It's what kind of side effects can you live with, and I think that's your own personal decision.
In my study too, we saw a lot of treatment regret because, of course, my study looked at men with erectile dysfunction after prostate cancer, in all fairness. And so we had quite a few people who had treatment regret after their prostatectomy. And I think the thing about it is too, so knowing who you are and making sure your urologist surgeon knows exactly who you are, how important sexual function is to you. Most people will say, my biggest concern is getting rid of the cancer. I would like to not be incontinent or leak urine, and I'd like to have sexual function in that order. But
Mm-hmm.
for you, if it's really going to be very life altering to not function sexually, your doctor needs to really understand that before they help you decide and look at all your options. So who are you and what is most important to you? And then also including your partner, listener, is super important. If they can come to those visits and be a part of that decision making, if you have a partner and they can come, we always highly encourage that. So I think that can be helpful too. Another question. My partner and I are overwhelmed trying to understand all the different options like HIFU, cryotherapy, and radiation. How do patients make sense of these choices without feeling paralyzed?
This is, I agree, it's a very difficult decision making if you're eligible for all this option. I think the first thing patients should do is to go to the physician who do these options, right? I believe that you will get the best idea about HIFU and cryotherapy if you talk to someone who does HIFU and cryotherapy, right? If you talk to somebody who doesn't do these treatment options, you may not get an idea. They are giving you an overview from what they have heard, what they have read, but they have not seen these treatments being done. So if you are interested in these treatment options, find a physician who offers these treatment options in their practice and talk to them. I think you'll get more option. But you're right, the decision paralysis is a real thing. And Sometimes some patients take much longer to make a decision, and then some of the focal modalities you're not candidate for. Focal treatments work best when you have a small amount of prostate cancer. And if you sit on it for too long, sometimes your disease progresses and then you're only eligible for radical prostatectomy and radiation therapy. So while it's good to take your time making a decision, but I think it's a reasonable time frame to make a decision in 3 to 4 months so that you can get treatment within the first 6 to 7 months.
I do think, like zero prostate cancer support groups such as that can be really helpful. And also, there's can be some good information online, but absolutely, you really need to go to the people who are doing these things to understand them better. And so look and see who's doing them in your area and find out more, definitely, from those urologic practitioners as well. So, at this point, I'm going to go to my centering exercise as we do, and I will come back to you in just a minute, and we will talk a little bit more and close out the episode. So I'll be right back to you. But for now, as we always do at this stage of the game, I would like to go to, as we close today's episode, okay, it's been a lot of technical information, a lot of medical information. So I invite you to take a moment for yourself. If you're comfortable, place one hand over your heart and allow your shoulders to soften. Allow them to soften. Take a slow breath in through your nose for a count of 4. And gently exhale for a count of 5. Again, breathe in your nose slowly and exhale through your mouth. Release, inhale again. And as you exhale, release the tension from your jaw, from your shoulders, from your stomach and your pelvic floor. Continue that breathing pattern, and every time you exhale, release any tension you feel in your body. If you happen to be navigating prostate cancer or you're supporting someone who is, remind yourself, I do not have to face uncertainty alone. I don't have to face uncertainty alone. My worth is greater than any diagnosis. Keep breathing. Healing includes both body and connection. I deserve compassion, support, and hope. Allow yourself one final slow breath in and exhale out. And remember, you are so much more than any medical diagnosis. You are miraculously made and so much more than that, and you are enough. Well, Vic, can you give us a sneak peek at what's up next week on Dr. Jeff Talks About Sex and Intimacy?
For generations, men have been taught that masculinity and intimacy is about performance, strength, control, endurance, and sexual prowess. But what if true masculine power isn't about performance at all? What if it's about emotional presence, safety, and connection? In this episode, Dr. Jeff sits down with Mike Elliott, host of the Sacred We podcast, who has supported thousands of men in reframing intimacy as a path to masculine liberation. Join us on May 26th at 7 p.m. Central Time to learn more.
But this week, gosh, thank you so much for guiding us through this path to understand this middle ground of focal therapy. So much good information packed into this episode. I just can't thank you enough. Do you have any final, maybe a one message that you'd like to give our listeners as we close out this episode?
Thank you, first of all, for the invite. I had a great time. My final message is that, prostate cancer is a disease which it's just not a cancer impacting an organ. It does impact patients' mental status, Eventually, the treatment impacts patients' quality of life in terms of urination, sexual function, and other morbidities. And as a practitioner, there are a lot of us who are available to just provide information and listen to your preferences and help you guide those decisions. And I think ultimately, whatever decision you make, uh, if you have made your own decision, most patients are happy with their decision. I think the regret is more if the decision is forced upon them. But I think if you make your own decision, more likely than not, you'll be happy with the decision down the line.
I couldn't agree more. So, listener, if you are struggling with the prostate cancer diagnosis, don't know where to turn, you can also go to Zero Prostate Cancer to the website, and you'll find among many different support group options, the support group that I run on the third Thursday of every month at Gilda's Club. That's here in Chicago. But there's online support groups for advanced prostate cancer, for African American men, for LGBTQ plus men as well. And so there is lots of support out there. You're not alone. And it can be challenging navigating this, but you will make the right decision for you, given the right information from several sources. And so just keep advocating for you, because no one can do that better than you. Believe in yourself and have a great one.
As Dr. Jeff talks about sex and intimacy, breaking down the science.